All right. I would like to welcome you to the latest and greatest political determinants of health, a collective conversation entitled Universal Health Reforms Are Affordable, Especially in a Period of Crisis. My name is Joseph Harris. I'm an associate professor of sociology at Boston University and also a member of the collective who's worked on issues related to universal health coverage reforms and politics. It is my great pleasure today to introduce to you Robert Yates. Robert Yates will be soon a visiting professor in the practice at the London School of Economics. He is previously head of the Center for Universal Health at Chatham House, and he'll be presenting findings from his work at Chatham House today. Yates is also an honorary associate professor at the London School of Hygiene and Tropical Medicine and a long-term consultant to the elders on their universal health coverage program. His principal area of expertise is in the political economy of universal health coverage, with a focus on advising political leaders and governments on how to plan, finance, and implement national universal health coverage reforms. He's previously worked as a senior health economist with the UK's Department for International Development and the World Health Organization, advising numerous governments in Asia, Africa, and Europe on health financing policy and health systems reforms. Please help me welcome Robert Yates. Robert, it's great to see you again, and please take the floor.
Absolutely, Joe. Thank you very, very much indeed. And greetings everyone from sunny London. So I think my talk today will perhaps be about sort of 25 minutes. And I'm keen to sort of chat about the politics of universal health reforms. And really sort of suggest that at times of crisis, this could be the time to be really exploiting the political determinants of UHC reforms. I'll just go straight through the slides. But obviously, if I say anything outrageously contentious or anyone wants to challenge me, do please feel free to sort of interject, maybe through the chat, and then if someone can alert me to that. Without any further ado, I'll just sort of kick off, and I'm sure, given this sort of self-selecting audience, virtually all of you will know what universal health coverage is, but I do think it's important to emphasize this definition that we're talking about all people receiving the quality health services they need without suffering financial hardship. So note in this definition, we're not necessarily talking about health insurance coverage. This is quite simply everyone getting the services they need without suffering financial hardship. And as I'm sure you all know, achieving UHC is inherently very, very political for these reasons. Because we're talking about it being built on foundations of equity, nobody being left behind, with services allocated according to need. So objectively, some people need health services more than others. So pregnant women and young children, elderly people, people with chronic diseases, are obvious cases. And we're talking about if you're having this financial protection, then logically you need a health system, which is funded according to people's ability to pay, because that's the only way that people with little money would be able to get the expensive services. So to achieve this, we need a health system whereby healthy and wealthy people subsidize services for the sick and the poor. And to cut to the chase on this, when it comes to financing, this can only be achieved through a predominantly publicly financed health system. So the key to UHC is through increasing domestic public financing and allocating this efficiently and equitably. And I've emphasized the word domestic financing there because I think in all reality, if we're talking about achieving UHC in big low middle income countries, looking at the needs, looking at the amount of financing required, this is predominantly going to have to come from domestic financing. Aid financing is not going to close these gaps. So it's all about how do you get the domestic public financing and make sure it's spent efficiently and equitably. And doing this is a very, very political process. I mean, all ministers of health would just love to have the magic wand to sort of create this public financing, but really they're going to need to extract it out to their ministers of finance who are often quite reluctant to sort of come up with sort of the funding for UHC. And as you'll see from my talk, I think our primary audience should be heads of government, people who head up governments, and they are the key to getting the public financing. And just to emphasize this, I'm a sort of a great Norwegian champion for universal health coverage. Gro Harlem Brundtland said at the high level meeting back in 2019, if there's one lesson the world has learned, you can only reach UHC through public financing. And this need to get to political leaders, I think, has been increasingly recognized by global health leaders. It's not good enough just to, win over the ministers of health. You've got to go right to the top. And someone who I think has really clocked this is Dr. Tedros, the Director General of WHO, who explicitly has been targeting political leaders to get them to increase their public financing. And hence this sort of interest in high-level meetings at the United Nations to go right to the top on this. And I think this is very wise. Now, until July, I was heading up the Global Health Program at Chatham House, and we were thinking coming out of the pandemic, what can we be sort of doing to sort of try and encourage political leaders to increase their public financing? And we established a commission for universal health, which was headed by two former heads of state. Helen Clark, the former head of government of New Zealand, former Prime Minister of New Zealand, and Jakaya Kikwete, the former president of Tanzania. And we set up this group to specifically think of ways that we could target political leaders to encourage them to increase financing with a view to achieving universal health coverage. And of course, this was, towards the end of the worst part of the COVID pandemic, with the world in crisis, and the thinking behind the commission was that so many of the world's great universal health systems have come out of previous crises. So might this be an opportunity to, in effect, use the COVID pandemic to articulate the case for UHC reforms? And there was very much this feeling at the time of great sort of political volatility that this seemed ripe to do this. And of course, we did see in the pandemic, the way that leaders responded or didn't respond to COVID had big, profound political consequences. So smart politicians, you think, realizing that they have to do right by the health sector in times of crisis. And, here's a slide of three leaders who, in part, lost their jobs due to their inept COVID response. Of course, Donald Trump, who was telling people to inject themselves with bleach in the middle of the pandemic. In the middle, our former Prime Minister, Boris Johnson, whose behaviour, particularly in organising parties in 10 Downing Street, led to his downfall. And then on the far right there, Jair Bolsonaro, the Brazilian president, who became a sort of great denier of the pandemic and who thankfully lost his job in the last Brazilian elections. So given all this, we were very keen to talk to the politicians to say, yes, if you don't do right by the health sector, it can have negative consequences. But there's very strong evidence of times of crisis, smart politicians using this to actually launch UHC reforms. And our commission looked at these trends sort of across the world, drawing on other research and those of many of our commissioners, and highlighting that really over the last century or so, in all regions of the world, at all income levels, there has been a history of crises catalyzing UHC reforms. The UK, I'm speaking to you from now, famously, we launched our NHS out of the rubble of the Second World War, as did Japan and France. Ukraine launched its last major UHC reforms after the first Russian invasion in 2014. In fact, the other person on the panel at the launch of our commission, the slide I showed you a moment ago, was Ulana Suprun, who was the Minister of Health, who pushed through those reforms, largely in response to that Russian invasion. But we've also, interestingly, seen UHC reforms come out of economic crises. In Thailand, after the Asian financial crash, In Cyprus, after the 2008-2009 financial crash, Uruguay, New Zealand. Helen Clark was telling us that, New Zealand beat the UK to publicly finance UHC because they launched theirs coming out of the Great Depression. China, a good example of a country that launched significant UHC reforms in response to the SARS epidemic of the early 2000s. Turkey, partly in response to earthquakes about sort of 15 or so years ago, I think. And also after major political upheavals, often new democracies replacing dictatorships. Brazil, very famously in 1988 with the SUS. Nepal after the civil war about 20 or so years ago. Rwanda after the genocide. President Kagame pushing through UHC reforms as a way to sort of try and unify the government. So there's a real history behind crises catalyzing UHC reforms. And so we went further though and said, well, what did those leaders tend to do in these circumstances? When they did want to launch big bang UHC reforms, and it's pretty obvious that in many cases it was for the political objectives of winning or staying in power. What did they tend to do? And we sort of distilled down these sort of lessons that seem to be the recipe for successful UHC reforms coming out of a crisis. First of all, the main objective is to achieve full population coverage. Sort of if you're serious about health for all, everyone getting the health services they need, you need the entire population to be covered. So you don't sort of try and segment and say, well, we'll just cover this group and that lot will have to sort of wait to the next reforms. So it was, a big push for trying to expand to full population coverage of publicly financed services. And another, I think perhaps the most interesting finding, and I do think this needs investigating much more thoroughly, but there did seem to be a sort of a price tag to this, that with approximately 1% of GDP, you can do this. You can move to a sort of full population coverage. And we saw country after country that had done this, a step increase in about 1% of GDP in public health financing. And then that money being spent as much as possible on extending services, primary healthcare services, strengthening health systems, getting rid of financial barriers, in effect providing free services or massively subsidized services, with a big focus as well people getting the medicines and diagnostics that they need, sort of free medicines for all, everyone can see a doctor. Pretty straightforward stuff when you think about it, but there does seem to be this sort of overall package that is the recipe that many of them used. And not surprisingly, having suddenly sort of created this universal, free, publicly financed health system, it becoming a flagship policy of the leader, people putting their names to it as their sort of great contribution to the health system and the population. And I just want to sort of whiz through now a number of examples of that. I've already mentioned the 1945 reforms when the Labour government got elected with a massive landslide against the expectations, I think, of Winston Churchill, who had just assumed that because he'd won us the war, that the population were going to vote him back into power. But Labour had a different idea that, they were going to create a nation fit for heroes. And one of the things about this was going to create a universal health system. And this is Nye Bevan, the architect of the NHS reforms, launching it on the 5th of July 1948. And famously, when we hosted the Olympics in 2012, this was the Olympic Stadium, and there was this part of the opening ceremony celebrating our NHS and it being free at the point of delivery. Now, I think it's fair to say it's hasn't been in rude health over the last 10 years or so, but I very much see that as the underfunding of our terrible Conservative government. And now that we have a new Labour government back in, perhaps we'll be, get back on course to rejuvenating our NHS. Other examples, Joe's very aware of this. I know that you've written extensively about the Thai health reforms. Thaksin responding to the Asian financial crisis, coming in on this universal health platform. Interestingly, the World Bank said that they couldn't afford to do this. Thaksin ignored them and launched very, very successful popular UHC reforms that are still doing very well to this day. And really, it was off the back of this that the rural poor, you know, really venerated Thaksin as their great hero. And you know, to this day, you know, he's very, very popular with the rural poor. And of course, his daughter is now the Prime Minister of Thailand. And I was just seeing the other day, I think she's just announced a new raft of UHC reforms, making the, you know, the people's entitlement portable across the country. So they've kept on this as a sort of very much sort of a family tradition, you know, the people of UHC in Thailand. China, another fascinating example of a country that I think in the sort of the 1970s and 80s, as it was liberalizing its economy and perhaps looking to the American economic model, really sort of neglected its public financing of its health system and allowed private voluntary financing to dominate. But really, it was the SARS epidemic that made the Chinese government, you know, sort of recognize that the system had become woefully inefficient and inequitable. And this led to big political unrest, you know, that people were very upset that they could no longer access health services. And it was in the mid 2000s that you know, the Chinese government launched these massive publicly financed health reforms to, in effect, to sort of try and re-socialize the health financing system. And as you can see, to take the financing burden off households. And Winnie Yip has written extensively about this. The need that this was politically driven, a lot of this, to respond to the SARS crisis. Rwanda, I mentioned, you know, one of the big things that President Kagame did to sort of try and unify Rwanda was to introduce a universal health system funded partly out of health insurance contributions, but really massively financed by domestic financing and aid financing. And it was interesting that coming out of the pandemic, where I think we saw the failings of aid financing, you know, and the West in supporting developing countries at the time of greatest needs. You know, countries like ours, let's be honest, you know, that we stockpiled, you know, the vaccines. We didn't fund Act A properly. We blocked tech transfers to developing countries. And I think many developing country leaders just, you know, the penny dropped that, you know, the West is not going to bankroll their health systems. And I took this, you know, from the internet, you know, that President Kagame calling when he was head of the African Union to prioritize domestic health financing, basically saying we're going to have to pay for this ourselves, folks. You know, sort of coming out of the crisis. And I just want to sort of illustrate, you know, this with, you know, here are some thumping big sort of countries in South Asia and Southeast Asia. You know, the fact that some countries have done this and are doing this, whereas there are others that patently aren't. And to ask the question, you know, how can we encourage these countries, India, Pakistan, Bangladesh, Myanmar's pretty much the same, that are just flatlining at a 1% GDP public health spend, and learn from these countries, Thailand, China, and there are plenty of others that have managed to find these quantums of public financing to launch their UHC reforms. So on this graph, you can see this was the Thaksin reforms of 2001, 2002, injecting money in initially. And interestingly, this was at a time when the military deposed Thaksin, that they put even more money into the health system because it had proved so successful and popular that they, you know, responding to the crises that there were in that period, they put even more money in. This is China, as I say, sort of post SARS, and this increase in public financing. This might not look much, you know, 1.5% of GDP, but this, of course, was at a time when Chinese GDP was going crazy, the massive increase. And this represents hundreds of billions of dollars of tax financing every year. So the question is, how do we encourage these countries to do what these countries do? And maybe the crises that we're facing today could provide us with this opportunity because we are seeing UHC and access to healthcare going up the political agenda. Prime Minister Modi in India has introduced, it's being dubbed Modi Care, but the official term is the Ayushman Bharat, which is an attempt to sort of try and increase health coverage. But if the truth be known, is not covering the entire population. It's just really people below the poverty line. And we're not still seeing those big increases in public financing that are required. Now, interestingly, in India at a state level, other state governments are taking a different approach. And I'm just highlighting here the UHC reforms implemented by the Delhi state government and under the former chief minister. And they've introduced universal primary healthcare in particular, and have been sort of attracting the attention of former world leaders, here's Ban Ki-moon and Gro Brundtland again, looking at this model, which is much more sort of aligned to the recipe I was saying in the past, that's of the Big Bang UHC reforms, universal entitlement, free medicines, free primary healthcare. So this is becoming a big political issue in India, and it's potentially one to watch. We can maybe discuss this more in a moment. Switching now to South Africa, where interestingly, the first thing that President Mandela did with his new ANC government was introduce universal free healthcare for, I think it was pregnant women and children under 6 in 1994. Now, subsequent presidents didn't make much more progress than that. But now there is a plan to introduce a national health insurance system, and in effect, a South African NHS. And at the start of the pandemic, the president was actually saying that they should use the pandemic to push through these reforms. Now, they've got a new coalition government in South Africa. Will they finally implement it? It's very difficult at the moment, the politics there, but potentially this could be a great opportunity for the new coalition government to negotiate a solution to this. And just to illustrate the type of work that we've been doing as part of the commission, we have been talking to political leaders in the midst of crises around doing exactly this. So this was early on in 2023. We spoke to Imran Khan in Pakistan, and you'll recognize Sanya Nishtar here, who of course is head of Gavi now, and Julio Frank, the architect of the Mexican health reforms. Imran Khan at that time still stood a chance, it would appear, of running for prime minister, and sort of suggesting that he might want to learn some of these lessons and really campaign on a UHC platform. Now, obviously, things are very delicate politically in Pakistan at the moment, and Imran Khan's party actually won the most seats in the parliament, but he's still in prison at the moment. But who knows what's going to happen next? So maybe another country to watch. And perhaps my last example. And it was very interesting. I took this screenshot off a YouTube video. You can actually see this online. In just before the last American elections, Hillary Clinton specifically saying to Joe Biden, don't waste this crisis of COVID. Now is the time to really ramp up your UHC reforms. Now, if the truth be known, I don't think he's actually done that. But of course, we've got another election coming up in the United States next month. Things in a very fragile state there. Goodness knows what's going to happen. But Kamala Harris was an advocate for a single payer health system for many years. And Tim Walz, the vice presidential candidate, actually said that he came into politics partly in response to, the death of his father and the medical debt that was then imposed on the household. So you can see that he's thinking about this. So maybe this could be the opportunity in the US. It'll be very interested to hear from our American friends online today. So just to conclude, this was our sort of overall findings from the commission. Many of the world's great UHC systems have come out of crises of various forms. My goodness, the world is in crisis at the moment. So I mean, I don't need to spell out to you that, the terrible situation in the Middle East and Ukraine and Sudan and plus with climate change and we are in a period of crisis and one can get quite depressed. But maybe this could be the best opportunity to pitch to progressive political leaders that they can use these crises to push through UHC reforms. And if there are merits in this approach, and my question for the audience today is, who should we be talking to? Where are the political leaders of tomorrow who could act on this? Because our commission, which has officially disbanded now, but we're still very much together as a group, would just love to have these conversations with the political leaders of tomorrow. So that's it with the formal slides. Just to say that if you want to email me about this, there's my email address, and I tweet about this or post things on X about this incessantly. So just follow me there. But look forward to the Q&A.